Okay, so I'm recording. We're going to talk about humidity and bland aerosol therapy. And I'm a bit sick, so if you can forgive me for my voice. But I'd like to get through this lecture so that we don't have to spend class time talking about it. Here are your learning objectives. Just make sure that they're always with your syllabus. They should be the same, but just in case, please check with your syllabus, and whatever's listed there is trumps what's listed here, but they should be the same. Okay, so in terms of what is humidity therapy, basically what it is you're adding water vapor to an inspired gas. So water vapor is the gas phase of water. Okay, so that's water vapor. An aerosol is different. Aerosol is when you have water in the liquid phase and they're just little droplets of water that are suspended in a gas. So they're light enough that they stay afloat in a gas stream. That's an aerosol. But water vapor is the actual gas phase of water. Okay, and so the purpose here is to help maintain normal physiologic conditions in the lower airways. Anytime somebody is receiving oxygen therapy, or if they have their upper airway bypassed, they end up with basically what's called a humidity deficit. So the natural part of our upper airways, specifically our nose, is to heat and humidify inspired gas. And when you're blowing dry gas in too quickly, or you're just bypassing the upper airway entirely, the nose and the upper airway can't do its job to heat and humidify and filter the inspired gas properly or as effectively as they normally can. So it's just too much gas flow, or it's just bypassed entirely. So you want to add humidification to people who have high flow rates or their upper airways bypassed entirely. Anyone who has thick secretions, you'll want to add humidification. Okay, so here are your indications, and I kind of just talked about this, but the indications are anyone who has dry gas at flow rates of greater than 4, you'll want to add humidification. Even if they have rates of flow rates less than 4, but they're telling you that they have feeling of dry, their nose is dry or whatever, you'll add humidification. So it's not like, oh, well, you're only on 3 liters per minute, so you know you don't get humidity. No, anyone who tells you that they have a dry nose or anything like that, then you go ahead and you add it. Overcoming the humidity deficit, like I said, when the upper airway is bypassed, you will definitely, absolutely have to add humidification, because the lower airways are not designed to heat, humidify, and filter dry gas. That's the upper airways job. So you have to add humidity and heat. Managing hypothermia, sometimes we will add heated humidification to help hypothermic patients come back to normal body temp. So again, remember, you want to like heat the core, and so in heating, having warm gas inhaled into the lungs will help to bring body temperature back. And then finally, you have bronchospasm caused by cold air. So sometimes asthmatics, if they go out into really cold air, they're exercising outside or whatnot, that it can actually trigger bronchospasm. So that might be another indication to get the cold air, or excuse me, humidification, heated humidification. Okay, so if the patient's on high flow and it's dry gas, this makes it harder for the body to heat and humidify the gas. And so what ends up happening is the point at which the heat and humidification, like what they call the isothermic boundary, the point at which it's all heated and humidified to body temp, it goes further down the tracheobronchial tree. And so again, like I said, the lower airways aren't designed to do this job. It's the upper airways job. So if it basically causes heat loss and water loss, and the body's working harder to humidify and heat the gas. So this can actually cause like structural damage to the airway epithelium. And it basically, the cilia, there's reduced motility in the cilia, so they stop working effectively like their mucociliary escalator function. It stops working as effectively. And then you get even more thick secretions. The airways become more irritable. They produce more mucus, and it just causes this vicious cycle. So you end up with like more thick secretions that become more and more difficult to expel for the patient, because it's like thick and dry and sticky versus loose and thin and moist secretions that are easier to bring up. So these people, and then they get more and more and more, and it just is a vicious cycle. Okay, so anytime you have somebody who has a dry and non-productive cough with evidence of retained secretions, you want to put them on humidification. And when you're evaluating whether it's effective or whether the humidification is working, you want to look at the viscosity of the secretion. So they should go from being thick to thin. Your patient's cough should go from non-productive to productive, right? And then eventually back to non-productive. You want them to cough everything out, you know, and then after that, they won't have anything to cough out. But like, let's say, for example, they have thick secretions, their breath sounds, they have lots of crackles, and when they cough, they're just not bringing it up. Then or very little amounts up, but then when you start humidity, what will happen is the cough becomes more effective and they start bringing up more phlegm, and then the secretions get thinned out and they become easier to expel, and then eventually they are gone. Okay, so that's kind of what you would want to see and be like, oh, my humidity is working. Okay, so here's some signs and symptoms of inadequate humidification. So if they have that, again, like I said, evidence of retained secretions, meaning this could be crackles on their breath sounds, the patient telling you like, oh, I just can't bring it up. I got stuff in there, I just can't bring it up. Infiltrates on their chest x-ray, which just means there's something in there. Okay, and here's some other things here that could cause be signs of inadequate humidification. Okay, so in terms of like, how do we deliver humidity? Well, we have what is called a humidifier. Okay, and so these are different devices that add water vapor to a gas. Okay, and so you know, we have different types, which we'll go into. Okay. In terms of the physical principles governing a humidifier function, so essentially a humidifier is a chamber of some sort with water in there, and then there's gas that comes into contact with the water somehow. Water vapor is added to the gas and it goes off and gets delivered to the patient. Okay, the other type would be that provides an aerosol, and we'll talk about aerosols, but is essentially your large volume or small volume nebulizer. Those are both aerosol producing devices. Okay, so in terms of the humidifier function, like how do you improve humidity or add more humidity to a patient? So you can do temperature, surface area, time of contact, or thermal mass. Okay, these are the things that govern the function or the effectiveness of a humidifier. So in terms of temperature, the higher the temperature of the gas, the more water it can hold. So for any humidifier, if you add heat, you improve the output of the humidifier, meaning you improve the effectiveness or the amount of humidity that can be produced from this humidifier. So add heat to any humidifier, you increase the output. Okay, I have a picture coming up that demonstrates this. So that's like the most important factor. Surface area, the higher the surface area, the more humidification you can get. So the greater the surface area, which means you have greater contact between water and the gas, and the more opportunity there is for evaporation to occur. So for example, if a gas is passing over a chamber, And if it's a small chamber, it can only pick up so much water vapor. But if it's a big chamber, it can pick up more water. Okay, so the greater the surface area, the more contact it can come into with the gas, and the more a humidification can be produced. And going along that line, the time of contact also impacts the amount of humidification that you can get, because the more time that gas is in contact with the water, the more humidification you can get. The less time, clearly there's less humidification. So you need to be able to have the surface, the gas must be in contact with the water, and then also how much time it's allowed to be in contact with the water will affect the amount of humidification that's produced. And then finally, thermal mass. So the more the more water that's in the humidifier, the more ability that it has to evaporate and produce more humidification. So like if you have a cup, let's say, and the cup is only a quarter full, well, there's not too much water that can evaporate to add humidification. But like, let's say if the cup was 100% full, there'd be a lot of evaporation that could occur before the cup ran out, right? So those are some examples that I can come up with on the spot. In this picture here, it's demonstrating that adding heat increases the output. If you look here, this is like a bubble type of humidifier. So the gas is coming down through here. It goes through this little filter, and then it breaks up the gas stream into little bubbles. And so the bubbles form and they flow out and they flow up, of course, because air goes up. And then it floats up through the water and then out. Okay, so that's basically how a bubble humidifier works, okay? And so clearly at high flows, your output would be less because the time of contact would be slower. So for example, if this bubble comes out and it's like like that, and then it would go out, it would pick up a certain amount of humidification. But that's, if I have a higher flow and it's coming out and going right out, that's less time of contact, and therefore less humidification, and less time of contact, less humidification that the bubble humidifier could put out. So that's an example of how time of contact could increase or decrease the humidification delivered. And that's why bubble humidifiers are not as effective at higher gas flows. Okay, so back to this example here, you can see the dry gas comes down. Here's the temperature in the chamber, and the gas coming out, you know, same temp. Okay, here's your absolute humidity here. Now here's how adding heat will increase the output. I have a heater, like a little hot plate underneath this chamber here. And now you can see the temp is raised up to 40 degrees Celsius. The function is the same, whereas the gas comes down out through this little filter thing, and then the bubbles get produced and they float up through the water, pick up humidification because it's heated. And remember, increasing heat increases the amount of water vapor the gas can hold. Check out here, the gas temp is same, but your absolute humidity has gone from 9.4 up to 51, okay? So it's a lot more output from the humidifier when you add heat. Okay, so this is what I was talking about. The bubble humidifier the gas stream breaks up into the small bubbles. There's like that little foam or filter thing that I was referring to in the previous slide. It produces smaller bubbles. Okay, and so this allows for, because there's a more smaller bubble, so each bubble on the surface of the bubble can come in contact with the water, which is the surface area piece, and then how long it spends floating through the water is the time of contact piece. Okay, usually we don't have heated bubble humidifier systems, but again, this is used pretty much exclusively with nasal cannula. And so again, anytime the nasal cannula is at 4 or greater, or anytime the patient tells you they have a dry nose or anything like that, you add a bubble humidifier. There's a little pressure relief valve to pop off or warn of flow obstruction to prevent the bottle from basically blowing up. Let's say, for example, the nasal cannula becomes kinked and now all the gas isn't able to flow through the nasal cannula. It builds up a lot of back pressure. And so as a safety mechanism, the bubble humidifier has a pop off so that it essentially won't blow up. And it sounds like a little whistle. And so we can practice that in lab and you can hear the little whistle. So essentially anything over 6 liters per minute, which by the way, you're not supposed to use a nasal cannula greater than 6, but at like higher flows, you'll see the humidifier can't really handle it. And it can, in fact, produce an aerosol because the bubbles are just blowing so fast. And if that happens, it's basically not appropriate. And once you do produce an aerosol, there is a risk of infection. So water vapor does not carry pathogens, but aerosols do. Okay, so there's higher risk of infection with aerosols. Here's a picture of a bubble humidifier. And so right here is the output here. This is where you would plug in the nasal cannula. This up here is the top, and this plugs into the bottom of your flow meter. And then you turn on your flow to whatever it is, and then you hook up your end of your nasal cannula to this piece and then hook it up to the patient. Okay, other types of humidifiers we have are called a passover humidifier. And then, so this is basically where the gas flows over the surface of the water. So this is like basically a holding chamber of some kind with water in it. And then the gas flows in through one end and out the other end. And as it's flowing through the chamber, it passes over the water. So that's why it's called a passover humidifier. And so there's different types. You have a simple reservoir type, which I would think is, or what I would say is probably the most common. We use that with a lot of our ventilator circuits as a passover humidifier. The wick type has absorbent material. So the wick, it's like almost like a candlestick looking thing. It's not really a candlestick, but it's essentially a type of sponge, looks like a little sponge. And the wick goes down into water. Because it's like a spongy type of material, it sucks up the water. And so the wick itself is moist, and as the gas flows over the wick, it picks up moisture that way. And then finally the membrane type, which I haven't really seen, to be frank. I don't think it's as common as the other two. It just is a passover, a simple reservoir type, but instead of having direct contact between the gas and the water is separated from the gas by just a membrane. Okay, so the advantages of this is that you can have humidification delivered at high flow rates. There's not as much resistance to these breathing circuits because at high flow, it's not, there's not a lot of back pressure that's being produced. So, whereas the bubble humidifier at higher flow rates becomes less effective because of the reduced contact time. That doesn't really happen in a passover type because you can increase the surface area and the thermal mass in a passover because, again, it's like a holding chamber. It's like a little bucket with water that sits in it, and then the gas is allowed to flow in and flow over, okay? What I like to think of a big passover humidifier is like, so people who live in, like here, we live close to the ocean, so we have higher humidity than like say Arizona, where there's not a big body of water, right, close by. So the ocean to me is like a huge passover humidifier because as the wind is flowing over the ocean, it picks up moisture, and that's why we have more humidity in these areas than in others. Okay, here's just a picture of what it would look like. This is your bubble again, okay? This is an aerosol, which I'll talk about in a sec, and this is your passover, okay? With a simple reservoir right here, your wick type here, and then the membrane type here. But like I said, this is just a big old chamber filled with water, And you can, if the chamber's bigger, it has a higher surface area. The more water you put in there, the more thermal mass there is. And the wider the chamber, the more time of contact, okay? So this is why at these higher flow rates, it's not as affected as, say, like the bubble, whereas the gas flows in, has to break into bubbles, goes zips right through and then out. This allows the gas to just flow in quickly, flow over, and then out. So it's not as impacted at higher flow rates compared to a bubble humidifier, which is why we use this a lot on our ventilated patients. Okay, so you can just see it's a pass over, right? Gas flows in, passes over the water, and flows it right out. Okay, here with the wick type, like I said, it's like a little sponge here. And if you picture like a little sponge and a little sponge, and then these are moist, this is sitting in water. And then the gas is going to flow in, flow around these wicks, and then out. And that's how they pick up the water. And then in this particular case, it would be water's down here, there's a membrane, and then here's the gas, okay? And so it would pick up humidification that way. The aerosol, this is like our large volume nebulizer or our small volume nebulizer. It's the same. The water gets siphoned up through a tube. The gas comes down and they meet over here, and there's a baffle or a obstruction of some sort. The gas and the water burst into a whole bunch of small little droplets, essentially, and the smallest droplets stay suspended in the gas and they can flow out. And it's not water vapor, it's like droplets of water that are in liquid form that are suspended in the gas, and they flow out to the patient. Okay. Here's a picture of a passover humidifier. So you can see here, this is a heat, like I like to call it like a hot plate. It's down here, it's like a hot plate. And then here's a simple reservoir type chamber right here. And you can see there's a corrugated tubing here and here. And so the gas is gonna flow in one side and then flow out the other side. Okay, and that's how it works. That's a simple reservoir passover humidifier. So in terms of problem solving, condensation is a big problem. So it can first of all, waste a lot of water. It can cause an occlusion to the circuit. So if you remember seeing the corrugated tubing on the previous slide, if that all fills up with water, it can just actually act like an obstruction to the circuit. So then gas cannot flow through. If it's completely full of water, the gas can't flow through to the patient. So it can act like an obstruction. The water that sits in that tubing can also be aspirated by the patient. If you pour the tube up, or if you grab the circuit and you lift it up, and the water is going to flow down with gravity, if it happens to be towards the patient can inhale all of that water, and that can be a massive pneumonia risk and get really big infections. So the condensation that can occur can really cause a big risk to patients. A pneumonia, aspiration, it can cause obstruction through the circuit, so you can't effectively ventilate somebody or provide enough gas flow to somebody. So how do we minimize these risks? Well, we add what we call water traps. So like on the large volume nebulizer, for example, which is condensation can build up from the water droplets falling out of suspension. And then also any condensation that occurs here as the gas is cooling. And I'll talk more about that in a sec. But we can add water traps. So the little water bag that you hook up with the large volume nebulizer, or you can put in a water trap with the other system that you're using, can collect that condensation. So we like to have those water traps placed in a low position so that with gravity, if condensation is occurring, or we can also call it rain out, if that's occurring, the water would be draining towards the water trap and then accumulate in the water trap and not in the tubing and not heading towards the patient. The other thing we can do is add heated circuits. So that's a big thing in respiratory care, is we have a lot of heated circuits, because if there is a heated element, like I called it the hot plate, so the hot plate and the water in the hot plate or the humidifier is being heated, but the second that the gas leaves the humidifier, it starts cooling down. And as it's cooling down, if it's water vapor that's traveling along, as it's cooling down, it will fall out of its gas phase and enter the liquid phase, which then creates the condensation. And so the more it cools, the more condensation will occur, and the more water you'll have in the circuit, which can lead to more and more problems. By having a heated circuit, meaning you have like little heated wires that add heat all along the circuit, it keeps the gas in the water in the gas phase, and so you prevent the rain out, you prevent the condensation, because the whole system is now heated instead. So that helps a lot as well. So again, you can see here the problems can be minimized with the use of water traps and heated circuits, and positioning circuits so that if there is condensation occurring, it occurs away from the patient. And of course, check your humidifier to make sure it's functioning properly, or your large volume nebulizer to make sure it's functioning properly. So how we make sure for the large volume neb is when you turn it on, you want to see the mist, and that's how you know it's producing an aerosol and that it's working. The humidifier, you'll check your temperature and you'll check the patient's secretions. And again, you'll always evaluate the patient's secretions to make sure that your humidification is adequate. Here's a picture of, you know, your humidifier here, and again, and it's under heat, and coming from here down to the site, you can see here that this is warmer and this is cooler, okay? And you're losing humidity from here to here, okay? So this is where all along here, the gas is cooling and falling out of its gas phase, and it's going into water phase, and condensation is building up, okay? So you would want to put in a water trap or something in here to prevent it from just basically flowing into the patient, okay? So that's one of the things that you would do. You could add a heated, like I said, a heated circuit or a water trap. Okay, so some other problems is cross-contamination. Again, like I said, so condensation is a great place for bugs to grow, and you provide a beautiful little environment for bacteria. So you want to get rid of that water, and you want to minimize the condensation. The other thing is they talked about frequently changing the circuit. And so when they say changing the circuit is not needed to reduce the chance of nosocomial infection, because the more you break the circuit, the more you can introduce new bugs. So sometimes it's better to leave the same old bugs in there instead of putting new bugs in. Okay, so we talked about minimizing that as well in order to reduce the incidence of infection. Okay, an HME, or a heat and moisture exchanger, this is called a passive humidifier. The other ones they talk about being active, that the humidifiers actively add humidification. This is considered passive, so the HME is called like the artificial nose. So what it is a little device that you can put at the patient's airway. Hey dog, just kidding. You can put it in the patient's airway, and essentially what it does is it's like a wick type, whereas there's like little sponge looking material that overall increases the surface area where there's gas and moisture in contact with each other. And so what happens is as the patient exhales, the heat and the condensate it's in our exhaled gas gets trapped in the HME. And then on the patient's next inhalation, it picks up that humidification and the warm air and humidified air on the next breath in. So it's basically like capturing your own heat and humidification and adding it to your inspired gas. Okay, so there's no, in terms of an external heat source or water source, it's just your own exhaled heat and moisture, which is then applied to the next inhalation. It's only so efficient, so you can't rely on an HME to do the job of like a heated system. So remember, you add heat to increase the output of any humidifier. So if you have an HME and you put it on a patient and the secretions are still dry and thick and they're not doing well, you would want to use a heated system. If they're hypothermic and you want them to get heated up, you have to use a heated system, okay? Unless they're on a hypothermia protocol, which we can talk about later. But again, it says here, it's only returns up to 70% of the heat and moisture to the patient. So it's not, 100% effective. So it's basically like you can use this in the first period, like let's say a patient gets an artificial airway placed, you can go ahead and put them on an HME. And then later on, you can evaluate whether they need to be on a heated system or not. Okay, so here's a picture of an HME. You can see one end would get hooked up to an artificial airway, and then this could get hooked up to your ventilator or so on, okay? And so essentially, as you exhale through the device, and then as you take your next breath in, you would pick up the heat and the moisture that was trapped in this little material. And in here, there's like this little spongy looking material that traps all the heat and humidification from your exhaled gas. Okay, blend aerosol therapy. So I just talked about an aerosol being water droplets that are suspended in gas. Okay, and so you can just see here in terms of a bland aerosol, you could use sterile water or saline. So these are the commonly used, these are the commonly used like liquids. Okay, so basically, again, this would be, this is an aerosol. It's not considered water vapor. Okay, water vapor is again water in the gas phase. An aerosol is liquid water in little tiny droplets that are suspended in the gas, and they're light enough to stay suspended in gas. Okay. And so what is, again, one of the big differences and why it's important is because depending on your system that you're using, water vapor is not supposed to be able to carry pathogens. Aerosols and condensate can carry pathogens. So in terms of bland aerosol therapy, it's almost like you're spritzing a little mist. Like if you have like a water spritzer and you're spritzing a little water mist into somebody's airway. Okay, so that's kind of what you're doing. And this can really loosen up secretions because water is basically going directly into the airway wall. And so sometimes we might use this to get somebody for like to help mobilize secretions if you need to get like sputum samples or something. So in terms of hypertonic saline, you might give that in through a small volume neb to get somebody to induce them to cough to get a sputum sample. Indications for bland aerosol therapy is presence of upper airway edema. So we talked about giving cool aerosol for upper airway edema, like post-extubation perhaps, like a nice cool mist to soothe their airway. We need to look this up and double check, but recently it was a standard of care for patients with croup, pediatric patients with croup. But I recall reading somewhere where they're saying there's no data to actually support this. So if they have a history of bronchoconstriction or airway hyperresponsiveness, you actually would not want to give this because remember, cold air can actually induce bronchospasms. So you don't want to give that to somebody. Okay, so so you can go ahead and we need to double check that, but I recall hearing at a conference that there's no indication for cool mist with croup. Okay, so we've talked about large volume nebulizers, but this is a commonly used device, pneumatically powered, meaning it's connected directly to a flow meter. So you have to have your flow meter. It cannot be hooked up directly to the wall. That's 50 PSI, you'll blow up your nebulizer, okay? So you have to have a flow meter and then you hook up your large volume neb to the flow meter. you turn it on and it works on air entrainment or air mixing to provide the FiO2. Okay, again, this is where the water gets siphoned up and meets the gas that's coming in, and they basically just blows up all the little water stream into little tiny water droplets that then stay suspended and go out through the outlet towards the patient. Here's what it would look like here. And you've all seen this already, so I won't spend too much time on it, but you can see the water's going to be coming up here. The gas is coming down through here. They meet in this junction here, get blown up into little small particles, which then the big particles fall back down into the chamber and the small ones stay and go out to the patient. Generally, well, what you will see is it's a large bore corrugated tubing that is then hooked up to one of, either an aerosol mask, could be a face tent or a tracheostomy mask, and I'll let you see what those look like. Here, this is a T-piece. Here's your trach mask, so if they have a tracheostomy tube, this is where it would get connected to their tracheostomy mask, which would then sit over the trach. A face tent just looks like this, and it would kind of sit below the patient's chin, and you might use a face tent, like say if the patient has facial burns or something where they're not tolerating a face mask. And then you have your standard aerosol mask here. Mist tents and hoods, we actually don't use these anymore. We might use an oxy hood or a little hood that would go over a baby's head, but we don't really use the tents anymore. This is where you would actually have a chamber, like literally like a little tent that would go in. You just put the whole baby in there, or the whole infant or pediatric patient in there, because they don't necessarily tolerate having things on their face. But the problem was that it would have a lot of heat buildup or CO2 buildup if the gas source got disconnected or whatever. So we don't really use those anymore. I don't think you'll ever see a mist tent. You might see babies on a hood. Okay, so some problems with aerosol therapy is infection is a big one. And then if it's just not working, so you have to check your connections, make sure that your device is putting out mist. And then the other thing would be noise in terms of compliance. It could be noisy, and then the patients complain that they can't sleep. Another problem is overhydration, because it's like water, like particles. You could just overhydrate somebody, and then again, bronchospasm. Okay, thank you for your time.